Good morning and welcome here from London. From all of us here, we're all feeling very good because it's nice and sunny after a long time. And I hope it is the same with you and hopefully gets better. So as I said, I will only reiterate one issue. Please feel free to type in your questions and answers through the talk, and we'll sort of host them at the end or subsequently. And if you do happen to put them in the chat, we will pick this up. But if you put it in the Q&A, it'll be easier. So thank you for that. And I will now introduce my colleague, Dr. Larissa Kerecuk, who is a consultant pediatric nephrologist at Birmingham Children's, is also done a lot of work for rare diseases and continues to with an expertise with autosomal recessive ARPKD. And we've requested her to talk to us a little bit about just helping differentiate perhaps the differences between the different types of polycystic kidney disease and how that might sort of present to us right at the start, so and the early years. So Larissa, over to you. Thank you very much.
Thanks very much, Manish. It's a real pleasure to be here today. And I am just going to share my screen as well with the PowerPoint, which is just there. Can you see that okay? No?
At the moment, no.
No, okay, let's have a little look again. Look. What about there?
It's on now. Fantastic.
Oh, excellent. Lovely. So yes, thank you so much, Manish. It is a pleasure to be here today. And I was just actually remembering that it was back in 2012 when we held our very first ARPKD patient support group with the support of Tess and her amazing PKD Charity. So yeah, which is why this is happening. So I've been asked to mainly talk about introduction and just an overview, which I will do, and then some of the things I will leave for the other speakers to kind of delve a little bit deeper. So without further ado, what is ARPKD? So I'm sure all of you who are here know that it's an autosomal recessive polycystic kidney disease. And like Tess said, it's a very rare genetic condition. The kind of incidence is about 1 in 10,000 to 1 in 40,000. It depends what population, and it depends how they've measured it. So it's rare anyway. And the two major problems it causes are in the liver and the kidney. And but some other organs, like the lungs, can be really badly affected as well, as I will tell you in a bit. And another thing that's really important with ARPKD, and this is what we've learned actually over the years, is that the problems can vary a lot. And the stuff that's often written in textbooks is not actually correct. I was taught that ARPKD was, mostly a fatal condition. Those that survive will need dialysis, very soon. And actually, that isn't the case. We're learning a lot more about it. The other thing that happens is that there's a lot of variability. So there may be two siblings affected, and they may have completely different conditions with variable, liver and kidney, and sometimes, very mildly one affected. So, so that's important to point out. And one thing it can mimic is, of course, autosomal dominant polycystic kidney disease, which is a much commoner condition. It's also known as the adult type, but actually it affects children as well, and it's about 1 in 1,000 rather than so much more common than ARPKD. It tends to cause kidney failure much later in life. It can affect the liver, but it's rarer. It is quite rare in children to affect the liver. So that is not what we're talking about today. But sometimes it can mimic it if the ARPKD is quite mild. So what actually causes ARPKD? So in this day of genomics and genetics, we are learning much more, and it's actually a gene. So it's a spelling mistake, or a big kind of a whole bit that's being cut and not repasted, as it were, from the gene called polycystic kidney and hepatic disease 1. And we only know about one gene that causes ARPKD. Other conditions like ADPKD, you have two genes, the PKD 1 and 2. So there may be other genes, but that we haven't discovered yet, but this is the main one. It's in the short arm of chromosome 6, and I'd just like to show you the chromosomes are packaged, where the genetic information are packaged. So we've got 23 pairs, one from our mum, one from my dad, and if you unravel all of that, you will get the actual gene, and the gene is essentially the instructions on how to make a protein, which is really in ARPKD, it's called fibrocystin, and that is a protein in the cilia. And the cilia, you may have heard about cilia in the respiratory system that clears away mucus, but that's not what we're talking about. The cilia that we're talking about is difficult. You can't see it with normal microscope. You can only see it with an electron microscope. And these little tiny things here that stick out, and they're like antennae. They're like little sensing devices. And fibrocystin actually kind of forms a complex with polycystin 2, and it basically maintains this little sensing device. Without this sensing device, the cells in the kidney and in the liver don't know which way round they are, and that's really important in organs like that, because they need to know which side there's got the urine so that they can reabsorb things, and in the liver they need to know where the bile is. So yeah, quite important. I'll tell you a little bit more about that. So I've already told you it provides instructions to make a protein, and the way that happens is your DNA, where your gene is, gets transcribed, get your messenger RNA so that it can come out of the nucleus, and then the cell makes it. And then once the cell makes it, it will just send it to the right places. It's all very clever. So anyway, that's enough for very basic science type stuff. We'll move on to actually the stuff that we see every day. What happens in the kidneys? The kidneys are often the major organ affected. And most people have two kidneys, and the kidneys look like this if you cut them, and they've got an outer bit called the cortex and an inner bit called the medulla. Now, the reason I'm telling you this is quite important. The bit that goes wrong in ARPKD is actually in this medulla bit. So the cortex bit is where the blood comes in and the blood is filtered, so all the kind of fluid comes out. And then in this bit, in the middle bit, most of the things are reabsorbed, and also the water is finally regulated. So if you've already had 3 coffees this morning to get here, you basically, your body's saying, you know what, I don't need water. We'll just get rid of that, so we don't need to reabsorb it. But actually, if you hadn't drunk anything, all night last night, you wake up quite thirsty, and actually your kidney will hold on to that water. And essentially this happens in this last bit here called the collecting duct. So this is where the filtering happens, reabsorption, and then this gets concentrated. In ARPKD, instead of it being a nice tube, the cells in there lose their polarity. So basically they don't know which way around they are, and because they don't know which way around they are, they can't form nice tubes. They instead will tend to form cysts. They will just kind of round up like little balls, and essentially this is what actually causes the cysts. So this is a picture of a ARPKD kidney, and you can see that there are lots of cysts on the surface. They're quite small, and they are basically just fluid filled, and the kidney tissue in between is literally in between, squashed in there. So it's they do look quite abnormal. I'll briefly mention the liver. So the job of the liver is to it's got lots of jobs, but for our purposes of ARPKD, it kind of detoxifies the blood filters the blood as it comes out, drains the gut, and it also produces bile duct. Now, in the liver, ARPKD causes a very variable condition, and there's absolutely no relationship with the kidney disease. So if the kidney disease is bad, liver may not be bad, but then at the same time, they both may be very mild or very severe. So you get two things in ARPKD. You get congenital hepatic fibrosis and then Caroli's disease. And they get two main problems: portal hypertension and cholecystitis. So as I was mentioning, portal hypertension, because the way that the polycystin is in the fibrocystin is in the liver, it causes, because it's not functioning properly, the blood vessels draining that blood don't form properly, and they have a lot of scarring. And with that scarring, the blood struggles to get through, and basically the pressure backs up, and it backs up in places like the veins that kind of drain the gut. So your gullet, your your lower bowel. So it's it can be very severe, and we need to monitor that. Now, cholecystitis is when you get infection of the gallbladder, and in the gallbladder, so that's that bit there. The job of the gallbladder, well, job of the liver is to produce bile, and bile gets stored in there, and then as food comes along past that bit there, the bile gets squeezed out so that it can be digested properly. When it's not formed properly, it all gets dilated, and then basically bugs from the gut can go up there and cause problems, and you can be very, very sick, and it's really difficult to diagnose. So that's just a picture of the blood vessels. That's what the normal thing should look like, and this is what ends up looking like, and a picture of the microscopy as well. So that's what's meant about congenital hepatic fibrosis and about Caroli's disease. Yeah. So in terms of, sorry, my cat has just joined me, and she's managed to open the door. So I'll just try and keep her quiet. Sorry about this. So in terms of timing of the condition, yeah, come on. So in terms of timing of the problems, it's really best to divide it into before birth, infancy, which is up to the age of 12 months, and childhood. And I'll go through these in sequence. So so before birth, what can happen is about 1 in 4 cases can be diagnosed. 1 in 4 to 1 in 2, you get bright kidneys on the scans, and if there's severe liver disease, what happens is the fluid, amniotic fluid, is low. And the reason that happens is actually amniotic fluid is mostly urine from the fetus, and that urine from the fetus is actually very important in helping the lungs develop, and basically the baby breathes in that fluid and the lungs develop. If the baby doesn't have enough urine in utero, then the lungs don't develop, and that can cause a major problem. So infancy, when the babies are born, the first 12 months can often be very difficult because these kidneys can be really huge, and if you've got lung problems and a large tummy, it's difficult to breathe. And people often remove one kidney, like I showed you in the picture, but also they'll be squashing the stomach, so it's really difficult to feed. Babies often born premature, they may have low salt levels, and they'll have varying degrees of chronic kidney disease. So they may have a very mild chronic kidney disease where they don't need, but they won't need dialysis for quite some time, or it might be quite severe, and they may well have high blood pressure. But the good news is if the baby survives the first month of life, they actually do really well. It's that first month that's crucial, and that's determined by the lungs. If the lungs are really bad, it'll be difficult to ventilate, and that's actually essential for life. But if you survive that, then actually the overall survival is much better. So what about childhood? So high blood pressure is really common. I've already mentioned about the kidney squashing the stomach, and that leads to poor weight gain, together with chronic kidney disease, together with breathing problems. Lots of things will cause your child not to grow well, and to basically struggle to gain weight. And it really is a battle in some cases. The kidneys are really large, and the largest kind of kidney to tummy size is around 1 or 2 years of life, and then it does get better. And that's important important to say, because you know, some people will just think, oh, we need to remove these kidneys, but that isn't necessarily so. And the other thing that I've already mentioned is about the kidneys not concentrating urine. So in a previous ARPKD support day, we asked the parents what they wanted to talk about, and they all literally said that they wanted to talk about bedwetting and how to deal with those problems, because and as a doctor, I didn't actually realize that that was a big issue, and it is, because they can't concentrate their urine. The other thing is because they can't sense that they haven't got enough fluid on board, and they will just keep sending urine out and water out with it, they are very prone to dehydration. So when they get poorly, you know, they often end up in hospital. But the good news as well, like I said right at the beginning, the chances of the kidney functioning at different ages is actually really quite good. So if you survive that first month, 9 out of 10 children with ARPKD will still have working kidneys at the age of 5. 7 out of 10 will still have their own kidneys at the age of 10, and 2/3 by the age of 15. And actually, by the age of 20, 4 out of 10 will still have their own working kidneys. And that is very different to what I was taught, even for my postgraduate medical exams. So this is actually very good news. And it's encouraging. So in terms of chronic kidney disease, this is, you know, what we do day in, day out. And often when we talk to families about any kidney disease, they often are shocked that we don't have any treatment for it. But sadly, there isn't any magic treatment for kidney disease. It doesn't regenerate. But what we can do is basically manage high blood pressure and manage all the urine infections, manage anything that's going to make the kind of kidney function deteriorate faster. So and then when the kidney function gets low enough, and you know, you plan this, you want to replace the kidneys, and you can do that by dialysis or transplantation. And we will later hear from Mr. Kazari, who will talk a little bit more about transplantations. So I thought what would be good is to have some case histories to just give you like a flavor, rather than just me telling you kind of random facts. So important to remember, extremely variable, each patient's different. And again, this is like a medical disclaimer, like Tess, what I mentioned here may never happen to your child, may not apply to your child, and each child needs to be managed by their own doctors. And that's why we still have doctors, and you know, we haven't been replaced by robots, because we need to kind of, you know, use our kind of experience and judgment. So that's important for you to remember. So don't, it may not apply. This is for you to just kind of get the kind of picture, as it were. So the first child that I want to tell you about is Arian. And this is a picture of me when I was much, much younger. I was a registrar in Birmingham, actually. This is when I first came to Birmingham from Guy's. And Arian is actually about 8 months there. And you can see that I'm holding his head. So he's quite delayed, and we didn't know he had ARPKD.
Larissa, can I just jump in and say you don't look any different now?
Oh, thank you. That's very kind.
I think that was quite recent.
Oh, really? Oh, yeah. Makeup's obviously work. So yeah, I'll keep buying expensive stuff then. So anyway, so little Arian was basically sent home after he was born, didn't have any major breathing problems, but he came back because he wasn't feeding, wasn't growing at just a couple of weeks of age. And then, it kind of became obvious that he had massive kidneys, and he spent he spent a long time on our ward. He was there throughout my 6 months as a registrar, and then a bit longer as well. We had terrible problems controlling his blood pressure, and you can see he's quite hairy as well. And that's because we had to resort to minoxidil, which is like horrible blood pressure medicine, because we just couldn't control his blood pressure. He had salt problems, and people sometimes would add salt, and it was just, it was a mess anyway. And we ended up having to remove one kidney, and then still didn't manage his blood pressure and remove the other one. So we changed from no kidneys, from 2 kidneys that were causing very high blood pressure to no kidneys, and then we had problems with low blood pressure and dialysis. So it was hard, but he was very difficult to manage. And yeah, so I've mentioned all these things. He had very large kidneys, didn't have major problems with his lungs though, and we removed not one but 2 kidneys, and his kidney function was kind of, it wasn't that bad, but obviously by removing the kidneys we sent him into kidney failure. So the low sodium levels, I'll just mention this, especially if there are medics in the audience or healthcare professionals. This happens quite a lot in ARPKD patients, and it's not due to the not having enough salt, it's due to having too much water, and this will cause water overload. And so people will often, especially if they don't know what's going on, they often give you sodium supplements, and that actually just makes the situation worse because just get more water overloaded. And in part that was what was happening to our little Aryan. And one promising thing is tolvaptan, which is Genarch, which is used for treatment in ADPKD. So that is potentially a future treatment, but of course it's not licensed, hasn't been trialed, so you know we need to do more work, but potentially this could actually work really nicely for this, but not quite yet. Removal of the kidneys, as I said, it's often done to improve ventilation. We had a child over the last probably 12 months ago who needed this because he just couldn't come off the ventilator, but it was really out of desperation that we did it, because you know that was the only thing we could do, and parents wanted us to do everything. As I said, leads to earlier kidney failure. There's no evidence that it helps, but then there's not a lot of evidence for anything that's done really, because it's all you know, lots of no randomized controlled trials. So you have to look at the individual patient. So I've already mentioned the blood pressure going from high to low, and low blood pressure is actually quite difficult to manage as well. So then I move on to our second patient, who's now actually transitioned to adult care, and baby was induced, baby well but large tummy, and actually many months later she was admitted to hospital with a hernia. And then when they and somebody amazingly measured blood pressure. We really like people who measure blood pressure, the kidney doctors. But anyway, they measured it, and in fact didn't believe it. So, but they did it again and again, and they called us. And then that's when we thought, oh my God, he's got a really big tummy, and this is So anyway, she's got a really big tummy. So we did did a scan, and we thought it was very likely to be ARPKD. So she went to renal ward as well. And the first year was quite difficult, not as difficult as Aryan. He had lots of admissions, but actually after that bit, her function kind of stabilized for a bit, the kidney function. She grew and everything, and she didn't need a kidney transplant until 8. And she's just, as I said, transferred to the adult hospital with that kidney still working, and she's done really well. She's still monitored for liver disease, but no major problems. And then the next patient I want to tell you about is actually the sister of the patient I've just talked about. So this was child number 4 of the couple, and this time, because we knew one of their children had ARPKD, they had an antenatal scan at 12 weeks, and that basically, you know, bright kidneys, so it was very, very likely. And then at that time, genetics wasn't done all the time, so it was just gone with clinical kind of diagnosis. Delivered, transferred to the renal ward, had high blood pressure, but because we had this little girl early, it was much easier to control it. We gained control easily, and everything was done much more proactively rather than reactively, which is often the best way to do it. Her kidney function was stable, but she had lots of episodes of sepsis, and people thought it might be urine, but urine never grew anything. They thought it might be just something. They just couldn't find where it was. And eventually she grew a really unusual bowel organism in her blood culture. And that's when the penny dropped that this may well be cholangitis. And that is exactly what it was. So infection of the gallbladder and all those things. So at that point, we asked the liver team to get involved. And actually she's still doing very well. Yeah, I'll leave it at that because you'll have more from Tassos on the liver. So, but what I did think was useful at this point was to talk about, about screening and about autosomal recessive condition. So what does that mean? So autosomal recessive means that you need, I'll go back one step, each person has 2 pairs of chromosomes. So that chromosome 6 with the PKD1 gene. So you need 2 working copies. So the darker one is the working copy. You need basically 1 working copy for it to be okay. So if you just have 1, you're fine. Obviously, if you have 2 working copies, you're great as well. But if you end up with 2 non-working copies of the gene, so there's no instructions going and to form that bit of the cilia, then that's when you get affected, and you inherit basically 1 of these chromosomes from each parent. So you go like from that one to that one, and then that one and that one. So you can see this is the combination. So you get 1 child, you get 3 children who are completely unaffected. 2 of them carriers, and then 1 is an unaffected person, and then the other would be an affected daughter. And this is your chances, because every time you have a child, like the chances, it's kind of rolling the dice again, and you're not guaranteed. Just because you've had 2 children with ARPKD doesn't mean that the next one's not going to be affected. So it's so they need genetic counselling. So yeah, if both parents are carriers, there's 1 in 4 chance of the child being affected, because I know that lots of genetic questions asked. So the next patient, it was actually a patient who we met. We did meet him. His parents came to our ARPKD support session in Kingston. I think it was 5 years ago. Anyway, he had been diagnosed with an ARPKD-like condition, and that was how he was being managed. Cystic kidneys, liver abnormalities, high blood pressure, had breathing problems, but they weren't the breathing problems right like at the beginning when he was first born. They were kind of developing later, lots of chest infections. And then because we're in relatively recently, he actually took part in the 100,000 genome project, like a lot of our patients have done. So we've actually got genetic diagnosis for them. It turned out not to be ARPKD, and but all this time we were managing him as if it was ARPKD, and in fact he turned out, so I think we got the diagnosis about 18 months ago, that he actually has this condition called Bardet-Biedl syndrome rather than ARPKD. So this is an even rarer condition, but it's what we call a ciliopathy. So all these conditions here, this is not for, this is just to show how many conditions can look a bit like ARPKD, and that may, and even ADPKD may look a bit like ARPKD, as I will show you in a tick. But actually the management hasn't changed for him. He's still being seen by liver, by kidney. He's regularly on the respiratory team, and because he's actually got bronchiectasis, which sometimes happens in children with Bardet-Biedl. So, but these conditions are all ciliopathies. So it's that cilia that's not working. So it's the same kind of family. So final case history you'll be pleased to hear. So this was a patient I met when I was my first year as a consultant, so I was looking through all her history, and she was like, I think she was 16, and I looked and I thought, okay, she had a UTI, urine infection at the age of 3. She had large cystic kidneys and high blood pressure when they did the ultrasound, and actually kidney function normal, liver, spleen were normal. So clinically, she basically was thought to have ADPKD, and there was no family history because one thing I should have mentioned when I was talking about ADPKD mimicking ARPKD is often there is a family history, because in AD you only need one bad copy of the gene, and basically then you get the disease, whereas in ARPKD you need 2 bad copies to have the disease. So in AD is 1 in 2 chance of basically passing it on to your children. So often you have a parent who has it, and a grandparent and a great grandparent, although it can happen afresh. It can happen as a new mutation when the baby was being kind of, conceived, as it were. Anyway, but that didn't matter, because she just, got managed with ADPKD. But I looked at the latest ultrasound, and it really didn't look like ADPKD. Normally in ADPKD, we get really big, large cysts, and it was just like the cysts, if anything, they were getting smaller and disappearing. And I was like, it's not quite right. Anyway, I thought, right, let's do some genetic tests. And I managed to say this was an important thing to do, because, she was 16 and she was, she wanted to know as well. So we did that, and she turned out to have ARPKD. And she was transferred to adult care with just chronic kidney disease. Her function was 56. So, normal is 80 to 100. So actually that's pretty good. And she had really no symptoms at all. She was really, really well. And no liver disease at all. But, we were basically, when we transferred her over to the adults, they will carry on doing the liver and the spleen scans. So, and this kind of, I go back to, your chances of having functioning kidneys at different ages. So at 20, at 20, you may still have functioning kidneys in 4 out of 10 people. And to me, even as a professional, I was surprised actually to learn this. And that's when I kind of got really interested in ARPKD and JEP, and then met Tess, and the rest is history, really. And we've come a long way, because I run the registry for ARPKD. So and in our registry we've actually got 46% are adults rather than children. So we've got a lot more adults with ARPKD than we ever thought was possible, so which is good. So that's kind of a quick run through the introduction and a bit of a few cases, so that you can remember them a little bit better. And I just wanted to say, in terms of support, especially, if you've got any queries, anything, is the PKD Charity, and they do have a helpline as well. And the closed Facebook page has already been posted on the chat function, but have a look at the website. Whenever patients are diagnosed, I always tell them to have a look at that, and and they've provided really fantastic support to our patients and families. And then the thing I was mentioning about is RADAR. So it used to be called RADAR, but it's rare renal, and that is a registry of rare kidney conditions. And then we have leaflets there for professionals, for patients, and part of our remit is to run these events as well, and to do research. So we're hoping that there are some new research projects which are being offered. Well, not being offered. We've had companies approaching us for expression of interest. So and that hasn't happened for many years, and that's really encouraging. So there's definitely stuff out there, and that's why it's good to have a registry, because the minute we have any new treatment or a new trial, we can contact those patients quite easily, because they consent for that as well. So all that's left for me to say is thank you very much for listening and giving up your Saturday morning to learn a little bit more about ARPKD.
Thank you, Larissa. That was really helpful to have that overview. And I know I don't see any questions at the moment, but we are on this virtual sort of platform. I think it's always important to sort of say a couple of things. One is there's a lot of information there, and you showed a really nice overview. So I'll let people sort of digest some of that and think through questions. And you can pose those questions even after the talk is finished. We can pick them up later. I think that was really helpful. I mean, a lot of people had registered, and we know for different reasons people are unable to attend. But this session is being recorded, so I think it'll be very useful to run through some questions which we have from before. So there is a question. Let's start from. We are based in India. My daughter was diagnosed antenatally. Do you have a branch panel in India? So I think probably would say no, but yes, we would be able to, your doctors can contact us, I guess, is probably, and discuss any information, and you'll get some more information. But please do visit the website and see if there's anything specific there which might be useful for you. Larissa, I just wondered whether I could just go back a couple of steps and just sort of think through, because a number of families that have, when we sort of initially diagnosed them, I thought your third case where we talked about the antenatal and prenatal for the child had a 12-week scan which showed a diagnosis of ARPKD. I suspect it was slightly later. So for all of us, we know that the initial dating scan is between 12 to 14 weeks. We then have an anomaly scan, which is at 20 weeks. And I guess it's important to emphasize that things change during these scans. And the sort of usually the diagnosis is made more near the 20-week scan, isn't it? With some changes. Like, I just wondered if you wouldn't mind just briefly describing that early bit, which is often a question for families, whether they would have done something different, or what is perhaps the take-home message for us as professionals. Thanks.
I mean, with this particular family, they already had an affected child, so they were very aware, because they had, I mean, when we have a family with newly diagnosed ARPKD, we always involve the geneticist, and we actually do some joint renal genetics clinics, because it's really important to be able to tell them. They often want to know, where does it come from, and why is it like that, and what's the chance of recurrence, and that's a really important thing to do, because a lot of people really worry about that. So this was a planned pregnancy, and luckily at that 12-week scan, it was, she had bright kidneys. It wasn't like, they didn't say, oh, this is definitely ARPKD, but they said it's suggestive, and they subsequently had lots of scans throughout the pregnancy, and of course they were given the option of terminating the pregnancy as well, but the family, they already had a child with it, and actually that wasn't the right thing for them, and again, often, sadly, we have families who lose their babies within that first month of life, and that's extremely difficult, and then they feel really scared of having another one. And this is why I was saying, each child's different and very, very variable. Just because the first one was was badly affected, it may not be the same, but for some families that's too much of a risk, and so it's a decision that has to be made with a couple and with their team, really, and we provide as much information as we can, but we don't sway them either way. So and that's really important thing to do. So later on in the pregnancy, at the 20-week scan, you will see brighter kidneys, and then it's more, it's much more likely. And then at this day and age of doing genetic tests, they will get a gene panel. If you don't know that there's ARPKD, and say that there wasn't a child affected, they would get what we call a cystic panel that's got like a number of genes that will get tested, and if they know that the child, a sibling has had it, they will just check for that particular mutation. So it's, it just depends on what's happening, and then you get confirmation, and then and if you then and that's done by amniocentesis, so which has a risk in itself. And then later in pregnancy, what you're looking for is the volume of the amniotic fluid, because that is the best predictor of what's going to happen, how badly your lungs are going to be affected, and also how badly your kidneys are going to be affected. And and again, say that you might be even 32 weeks and the fluid is really low, it might be, you may be offered an early delivery, but again, you may be offered a termination because, it's a medical condition, you can do that. So, but again, that's something for each couple.
Yeah, no, thank you. I think the key thing there perhaps to flag is that early scans do change, and I think the important thing, you get bright kidneys as opposed to often cysts in the kidneys which are visible, and there are lots of differential diagnoses for those bright kidneys. But I guess for a clinician and for families, I think it's important that that is discussed with the kidney team potentially, and depending on, like you were saying, changes in the scans where the LICA volume goes down, then a early plan is made to deliver in the right place, and all those options are discussed, as you said.
Absolutely, and we meet them beforehand as well, and and that's really, really useful. Absolutely, involving the kidney team, and there's different setups in different centres in the UK, so it's a bit variable, but yeah.
So thanks. There's a question. I'm just going to read it out from Karen. If blood pressure is undiagnosed, so if hypertension is undiagnosed and later discovered and treated at an early stage, is there a potential for permanent damage from the period when it was undiagnosed? And I think Karen sort of mentioned about her 13-month-old who took a little time before the blood pressure was diagnosed to be high, and that's just really wanted some reassurance relating to that. I don't know if you were able to comment.
Absolutely, it often takes a while to diagnose high blood pressure because people will do it and not believe the machine. Some centers don't do it properly with the Dopplers, like you should do it. But essentially, no, I don't think a delay in treatment would cause any permanent damage. Normally hypertension is quite silent, so your heart may get a little bit thickened, but once you treat it, it actually improves. And you have to have several years of untreated hypertension for it to have an effect. So if the blood pressure problem was picked up at 13 months, that's pretty good, and actually I wouldn't worry. And that's just monitoring and keeping it as stable as possible. So yeah.
So yeah, Karen, I would add to that. I mean, I think it's an important point you've raised. So just specifically for the question you asked, I think I would agree with what Larissa was saying, that if you treat it in time, obviously the earlier we pick it up, the better. But if there are no immediate problems, children are hugely resilient, built to live till they're 100, and so their heart and their blood tubes work very differently to us older people. And so some short period where the blood pressure might be high and perhaps not diagnosed at, it usually has no consequences. And once you treat it appropriately, that's the most important thing, because it does impact on how the kidneys are going to be working subsequently. I think from what I have noticed, and I'll request Max perhaps to come in on this, is that there often is a need, even when your child's been diagnosed to have this condition, to monitor the blood pressure, because sometimes it doesn't quite show up as high blood pressure right at the start, and can then progress. And I'm not sure I understand it very well, but can progress to become quite difficult to manage, needing multiple medications, not because of people not knowing how to, but in my experience, is one of the most difficult set of blood pressure problems we find in our little babies, and it just needs a frequent measurement and sometimes multiple drugs, and surprisingly it melts away after 1 year or so of age. So I don't know, Max, if you wanted to add some there and reassure Karen perhaps. Thank you.
That's not a lot I could add. I mean, you've pointed it all, Larissa, and you have pointed it all out. It can be very a complicated situation. Blood pressure in ARPKD can be very high, especially in the first year of life. I think Larissa made a very important point by saying that sometimes doctors tend to add sodium because of the low sodium levels that are measured in the blood, and that is something that may then be counterproductive in terms of hypertension. So it may actually contribute to increasing the hypertension problem. So that's just something to keep in mind. It's as with many of these rare diseases, this is something that many of the doctors just don't know. In other conditions, it may make sense to add some sodium, but in ARPKD specifically, as Larissa has pointed out, we currently think it is rather a problem of too much water than losing the salt. And yeah, as you said, sometimes these especially the young kids need 2, 3, 4, 5 different types of antihypertensive medications, and it's just something that as a team, families and doctors need to try to to struggle with and get through the time. It can become better over time. That's also my personal experience. But we do not yet fully understand why it is so pronounced in ARPKD.
Thank you, Max. That's really helpful. I just wondered whether from the, I'm sure the registry you've talked about, is there any other learning experience relating to that sort of trajectory? I know in the past, and in one of the cases that, I think it was your first case, Larissa, you pointed out,
Arian.
where you had to remove both the kidneys, and that's often in the context of very high blood pressure and difficulties in controlling.
Absolutely. And what was happening is, I mean, this is going back, I think that was about 16 years ago now, so it is a long time ago. And Arian is actually in the process of transition now, and he's taller than me, as some of you know. I've actually, that's not hard, but anyway, but he's doing really well. But he was very, very difficult to treat. And of course, the more some of the hypertensive that you add, especially like your calcium channel blockers and some other medications, will actually cause fluid retention. So that was what we were getting. We were getting fluid retention. We didn't have enough of kind of volume to feed him, so we were getting into big trouble, and I think he was the most difficult one that we've had. None of the other ones that I know have had such a difficult course with the blood pressure. So individual patients have issues, and it may be that they've actually got something else going on. It may be that they've got some accelerator gene, or they've got another genetic defect that may actually cause the condition to actually get worse, and may exacerbate the problem.
Yeah, no, that's helpful. I think we've got quite a few questions, which is really nice. So Karen, thank you for Karen sort of just updated that her little one's now on 2 medications from 3, and he's getting bigger. So I think I would also point out there, Karen, you don't have to keep increasing the doses, as you see, and so that's just generally reflecting that he's getting bigger, the blood pressure is getting better, and that's fantastic. So I'm really delighted to hear that. There's a question about the youngest age. What is the youngest age you have requested a nephrectomy to your ARPKD? Was this due to BP or growth, or a combination of both? I think I think partially you answered it, Larissa, already. I think we've been involved in a couple of cases, and we'll probably come back to that question with Max and Nikos, Mr. Kesaris, later. This question, I think it might be something I will request Max to sort of perhaps hint on. If sodium supplementation is to be avoided, what is the alternative? Yeah.
Right. The alternative would be to try to add a little fluid to when feeding the kid. Obviously there are some limitations. Obviously kids need some fluid and food, but if there's a chance to sort of a condense feeding, if you will, then that may be helpful.
Yeah, that's exactly what we do, concentrate the feed. And you know, but yeah, often they're very thirsty, but to concentrate the feeds, that usually does the trick, because often you need that amount of fluid for the feeds just to get the calories in, but you actually don't need all that fluid. So if you concentrated the feeds, that's how we do it. So you try and avoid giving any sodium supplements, really.
Fantastic.
Larissa,
I would highlight.
Can I ask a question? Concentrate the feeds means putting in less fluid.
Yeah, but I would add there, you know, we most of us work with expert children's dietitians.
Yeah.
And you know, it's not something we would recommend you should do it on your own.
No.
You know, it's definitely something, you know, you would have, you know, pediatric kidney dietitians sort of looking after you and your little one. So that's the way to go.
Thank you, Manish. This is really very, very important to
absolutely.
Because...
No, we don't do any cookery. We just let the dietitians tell us what we just kind of ask for their help, and then they come along and come out with this formula, and you're like, oh, thank God for that. So
I think what it shows is this is really you know, highly specialized medicine of a very severe condition and a rare condition. So you do need a strong team to support you with different aspects.
So Max, I totally agree that this strong experienced team is what is needed, and you know, sometimes it's really worth. I know there are some health professionals on the call will be listening to this, is to pick up the phone and speak to a team which might have been dealing with such cases. So, and I know we do. So nothing like being able to just chat about some difficult problems. Another question, please, can I ask? I'm keeping an eye on the clock. I know we are. So please, can I ask, at what point do you stop the BP medication? My 10-week-old is now 10-week-old is on 6. And I'm just wondering about what point would this stop? So I think, Claire, without knowing the details of the case, and I might ask Tess to sort of, and Jane to sort of help with any specifics. But, you know, in general, I think our clinical experience would be that this is perhaps the time when the blood pressure is at its worst over this first few months and first year. And so we generally are just guided by what the numbers are doing, and we try to keep them in a good, safe range. And there are a lot of difficulties in measuring the blood pressure, of course, with these little ones, but you know, as long as we're doing them sensibly and systematically, and you've got a plan in terms of what numbers you are aiming for, and most importantly, as long as your little one is growing and thriving, then that's all we want to do, because we do know that these blood pressure medications will be not needed in that sort of dose and intensity as these babies get bigger, and surprisingly beyond 1 year there's a dramatic change often in their needs. So hopefully that'll improve, and then soon, and I think last question we'll take before we go on. So is there any connection between ARPKD and heart palpitations? My son has had a few incidents of this and fast breathing episodes. He has had ECGs and has shown no problems. So Larissa, and then I'll request Max to make a brief comment if there's anything specific you know of.
So, I mean, there is, so we actually did like a big review back in 2013. Sorry, my cat has joined us again. It's a bit in the US, where all the experts came together and reviewed all the literature. And no, there isn't any link between heart palpitations. However, some of the medicines we use, such as amlodipine, nifedipine, doxazosin, will all cause high heart rates. If they've got like some other medication like salbutamol, or if they've got something else going on, they may have it. So it may be completely unrelated, it may be medication related. So yeah, so you have to kind of take a step back and have a look at the whole picture.
Fantastic. Max, any other additional points?
No, just fully agree.
Yeah, no, I think it's you hit it on the head, Larissa. It's more often to do with the treatment of blood pressure, and sometimes to treatment of the potassiums, etc., which come with trying to manage it. So I don't see any other questions. And I think just looking at the clock, we are 3 minutes past.
Sorry, Manish, I've actually got 2 questions, just very quickly.
Oh, go for it.
One, what's the name of the cat?
Yes, I was wanting Larissa to introduce the cat formally, actually.
The cat is called Mia. She's here actually. Hold on, Mia, come here.
Hi, Mia.
Jane, I was going to request you, if you're very good with these, you know, if she's, I'm sure, got a Facebook account or something, you could.
There we go. Let's say hello, Mia.
Mia could join as a panelist.
We can have a whole
Mia, and
page.
I've got another one called Freya, but she's sleeping.
Excellent, thank you. It's a welcome addition to the event. But my other question was in relation to the case study of the child who was diagnosed with ADPKD, that in fact had ARPKD. I want to know, I'd like to know, is that a common occurrence? I mean, we may want to cover it later, but I think I'd like to pick that up later, actually. I think it's quite an interesting one, because I know we are actually now over time and we're ready for Max. So I don't know.
I'll just answer it really quickly from my point of view. That was the only case I've ever seen of that. And I've been doing this for like quite a long time, like 20 years in Reno. So not very common, but at the beginning, there may be some, some doubt and some confusion. And now, because we're doing genetics a lot more, we are getting more unexpected things. And, it's not unusual for us to get through the 100,000 genome, to find actually sometimes new genes, or sometimes you find that actually they've got double mutations and then an extra mutation. So you find lots of unusual things. So we're learning a lot more about this. But that kind of an ARPKD to then actually be then diagnosed with AD is quite rare, and probably in this day and age of genetics, probably less likely to happen.
Fantastic.
Right. Okay. So the occurrence of being diagnosed with AD when it's in fact AR is rare.
Yeah. Sorry. Yes. Yeah.
Thanks. Okay.
Yeah, that's what I meant. Sorry.
Back to you, Manish.
No, that's great. Thank you. I'm sure Max will pick that up as well. And